There is already a question in the chat.
Yes. So I think that they're just testing they're testing their chat box. I think they're testing the chat box.
Yeah.
There is no.
We've tested the audio and video. Now we are testing the chat box.
There is no specific role in the diet on Hashimoto thyroiditis. You just have to see how cuttable the patients are. If they're losing weight, then you have to make some recommendation. But there's no specific diet in this specific condition.
Questions have already started coming in, Professor Remy. So great. So I think most of them may get answered, but you will be there busy answering them.
Okay, the next question. Question about IBS and IBD. IBD we will discuss now. In IBS, FoodMap is quite a good option today. If you find out some difficult food items, then to remove them, it's quite a good option today. And
quite a few of us have done this course from Monash University on FODMAP.
Yes. Okay, very good. No, FODMAP is very, very common today. It's not so easy to do for the patients, but some of them have a good result, but some of them you can do whatever, they will never lose their IBS. It's also a lot of psychological
what we
problems.
have done in our department, Professor, is that we, in our dietetics department in the OPD, we have a chart of what is low FODMAP and what is high FODMAP. And we ask our patients to click that on their camera so that it's easy for them to remember what is low FODMAP and what is high FODMAP.
Excellent.
And we are also very, very happy in IBS patients at least.
Yes, yes.
So should we start?
Yeah.
Anita, you are the boss.
Yeah, I think so. It's exact 5:01. I think we are ready to start. So a very, very warm welcome from Delhi. It's good morning to some, good afternoon for some, and good evening to some. So warm welcome to all of you. I, Anita Jatana, consultant dietetics in the Crystal Hospital, would like to extend a very warm welcome to all our esteemed speakers, chairpersons, and participants for another Gap Year session, which is in collaboration with Global Dietitian Community. The session on role of nutrition in gut health, the forgotten organs, with trillions and trillions of microbes, which we all know has a very important, crucial influence on health of a person. Today we have very senior known speakers, Professor Remy Meyer from Switzerland, who will deliver a talk on challenges on achieving MNT in inflammatory bowel disease, and Associate Professor Franklin Marcus, Head of Hypertension Research Laboratory, Monash University, who will enlighten us on gut microbiome, a novel tool to lower blood pressure. So, requesting everybody, please keep yourself muted during the session. You have a lot to learn today, and post your questions in the chat box, which I think are already flowing in the chat box. So taking this forward, I'd like to welcome and invite Dr. Mahesh Goenka, Director and Head Institute of Gastrosciences and Liver Transplant at Apollo Hospitals, Kolkata, and National President of the Indian Society of Gastroenterology, to take the session forward. Dr. Mahesh, over to you.
Thank you, Ms. Anita, for asking me to be here for this very important, interesting session. It's really nice to see two senior people going to talk about nutrition and microbiome. I just would like to say that nutrition is possibly important in all spheres of medical fields, whether you talk of cardiology, endocrinology, nephrology, and so on. But I think gastroenterologist is more married to nutrition than anybody else is. In fact, some of the important institutes in India, the Institute of Gastroenterology is called Institute of Gastroenterology and Nutrition, because they are so closely linked to one another. I'm so happy to be a part of this. I think also another issue which we always ponder over is that when you talk about nutrition, whether it is a medical nutrition you're talking about or a general nutrition you're talking about, because we see when we go out to the malls, we find a lot of nutritional agents being present in the pharmacy as well as in general grocery stores. So I think that's a very fine line between the general nutrition and the medical nutrition. And I'm sure we would have some address to this aspect as well. So it's my proud privilege to introduce the first speaker, Professor Remy Meyer, and who is from AMB Gastro Center, Basel, Switzerland. He is working at the University of Basel and is a gastroenterologist, hepatologist, and as I said, a combination of gastroenterologist and hepatologist along with a nutrition expert. Now, I was going through his resume, and it's too long for me to even talk about it in detail, but to summarize, he is associated with a lot of associations, nutritional as well as gastroenterology related, and he has published extensively with peer-reviewed articles, original articles, 33 overviews. He has written 10 books, he has written 62 book chapters, and almost 200 abstracts. So it will be nice to hear Professor Remy Meyer today on this very important subject of IBD and nutrition. Professor Remy, please.
Thank you, Marsh. Very nice introduction. And just to mention, I'm already retired from the university since 8 years. So it's a long time ago I was working in the hospital. I'm still in a private institution, but it's only part-time, and I enjoy life more. And it's very nice to have 11 grandchildren and a lot of other things to do in my life now. But still, one of my major interests is nutrition. I'm still the co-chairman of the LLL Lifelong Learning Program of Aspen, and it's still my baby, and the baby is also now grown up. It's 18 years almost, yes. And we have trained more than 82,000 people in the LLL program in the last years. It's really amazing how this program is working. So today we will speak a little bit about nutrition in IBD. IBD was one of my major patients' diseases, and over the years, a lot of things changed. A lot of new drugs we have at the moment to deal with this patient. Unfortunately, in nutrition, there is not so much available. Nutrition is really a part of this treatment of this patient, but we have not found the Graal or the golden bullet for nutrition in this patient. So I will share my slides. I hope you see the slides.
Yes, we can.
Okay, so we go back at the beginning. Okay. So nutrition in inflammatory bowel disease. You know, when we speak about inflammatory bowel disease, we have two distinct diseases, as Crohn's disease and ulcerative colitis. Both have their specific backgrounds, but the main characteristics for both are they will be present as an acute disease with a lot of drugs and good things we have to in our arsenal today to treat this patient. We bring them in remission. Remission can also be longer with specific drug treatments, but also some have no relapses, but some of them will relapse in the near future, whatever we do. When you look on the background, more and more data we have on the background, and it's clear the genetic background is important, but also the environment factors are more and more important. Antibiotic used in the past, diets, more hygienic diets, more Western diets, and also hygiene plays a very important role. Too much hygiene, too much safe food, too much safe environment is not so good for prevention of these diseases. And when you look on a normal gut, and you know, more and more we know about the microbiota. We will hear more in the second presentation about this, but in a healthy gut, the microbiota are very nicely balanced with the commensal, the anti-inflammatory bacteria, and the harmful bacteria. As long as we have a high diversity, there is no attachment of the bacteria to the intestinal wall, there is no epithelial barrier changes, and so we have a healthy gut. But if all these things comes together in a negative way, we have altered microbiota, we have a loosened diversity. It means that the harmful bacteria will increase and the commensal will decrease. So these pathogen bacteria, they can attach to the mucosal wall. They can damage the epithelial barrier. They damage the tight junctions. There is an increased adherence. Also some mechanism to defend this. They are also deranged like defensins and like others. And so this bacteria will interact with the intestinal immune system, and this will cause a chronic inflammation. When we look on the epidemiology, the prevalence of ulcerative colitis and Crohn's disease are more or less the same. Around 50 to 20% are diagnosed during childhood. And what is very interesting to see, in the past, there has been a high incidence of IBD in European northern countries, in the UK, in the USA. In these areas, there is only a slight increase in the incidence. But what is very interesting, in the areas of previously low incidence, Southern Europe, Asia, and most developing countries, there is a steady rise. It is unclear if this increased incidence of IBD is due to improved diagnostic procedures or unknown or some known environmental factors. But I think both things play a role here. Also, it's very important to know that the incidence is higher in white than in blacks, and is higher in socioeconomic groups. Also, this maybe has something to do with hygienic conditions. And also, the diseases are more prevalent in the urban compared to the rural areas. So if you have children, it's good you go to the farmer's place. The children should dig in the dirt. They should eat the good bacteria to make a strong immune system. When you are living in the 120th floor in New York in a completely sterile flat, you have not this exposure to this good bacteria in your childhood. This is some data. You see Asia, Hong Kong, Korea, Japan for ulcerative colitis, Crohn's disease. And in the 80s, there was not very much of this kind of patients present. But you see over the years, there's a steady increase in all these areas for both diseases. Some ideas: more refined carbohydrates, more unhealthy saturated Western food, more hygiene, whatever could be a cause. But a lot of things we have to work out here in the near future. Some good news: maybe a greater intake of omega-3 fatty acids. Fish oil may decrease the risk. When we look on this more in detail, at the moment, there is no specific nutritional habits have been found to be involved in the pathogenesis. A lot of things were looked at, but the answer is not absolutely clear. But there is some protecting role, and it's clear when you look on epidemiological data that breastfeeding could have a preventive role. Breastfeed have less Crohn's disease, less ulcerative colitis than the not breastfeed. It's clear if you have the disease, if you have inflammation, the nutritional status is impaired in this patient. And on the other hand, nutrition treatment improves the outcome. And also what you have to consider, nutrition plays a different role in the acute attack than in the remission episodes. So weight loss is very common. It's more in a Crohn's disease than ulcerative colitis. And the reason is mainly that in Crohn's disease, the whole gut can be involved. In ulcerative colitis, the small bowel is healthy. So this may be a reason why weight loss is more present in Crohn's disease. So Crohn's disease is a little more, but it's significant than in ulcerative colitis. And if a patient has to be hospitalized for Crohn's disease, about 75% have a weight loss in the previous episode, in the previous time. So nutritional screening and assessment in this patient, as in other situations, is very crucial. What are now the aims for nutritional support? We like to treat or to prevent nutritional deficits. We like to reduce disease activity, clinically, laboratory, or endoscopic, or even histologically. And also, we like to reduce the need for surgery. In the acute disease, everything you can use according to the underlying problem of the patients. Better oral nutrition support, or if it's not enough oral, you can also give some recommendation for oral nutritional supplements. In some situations, severe cases, parenteral nutrition may be important, but this is really the last step we take. And in remission, the best recommendation is a healthy diet. We will come back. Maybe some probiotics in ulcerative colitis have a beneficial effect. So is it generally accepted that undernourished patients and patients with high disease activity need to have adequate nutrition support? But on the other hand, there is no specific IBD diet that can be generally recommended to promote remission in these patients with active disease. And several studies have shown that nutritional status cannot be improved only by nutritional counseling alone. You need to do more here. What is also interesting, that artificial nutrition support is more beneficial in Crohn's disease than in ulcerative colitis. When you need specific nutritional support, and nutrition is the preferred route for nutritional repletion. And if also, when you also introduced oral nutrition supplements up to 600 kilocalories, the calorie goal cannot be achieved. It is clear with an exclusive endonutrition, around 60% of the patients with Crohn's disease can be expected to achieve remission. But the problem is it takes a long time to induce remission. In children, it is different. In children, the first treatment option in Crohn's disease is endonutrition. Endonutrition is more effective than drug therapies. And in addition, in children, we like to avoid corticosteroids because of growth health, because of bone health. If you need tube, a nasoenteral tube is used first. And what is also clear, endonutrition has not shown any effectiveness in ulcerative colitis patients. When we look on the data on endonutrition versus steroids in Crohn's disease, a lot of meta-analyses have been done, and the first one was already done many years ago. But it's clear corticosteroids are acting faster, and they are acting in a more number of patients. But it's really amazing that there's no study available using endonutrition and steroids may be compared to endonutrition alone. So this has really been neglected all the time. A lot of specific diets have also been tried to improve the situation. When we look on all the data on exclusive diets, no clear effect. Elemental versus polymeric, I will come back on this. Diets with different fat components, no clear effect. Diets with pre and probiotics have been used. Also here, the effectiveness is very, very low. There are some data in children and young adults with a diet including the anti-inflammatory cytokine growth factor beta. A great hope was diets including glutamine, but also here, no effect. Short-chain fatty acids, butyrate has a good anti-inflammatory activity, but only there have been some effects shown in ulcerative colitis, and all the phytonutrient studies have shown no effect. So what has changed in the past? We started the elemental diets, then we went to polymeric diets, and it's clear elemental and polymeric diets have the same efficacy. There is no difference between them. And because polymeric diets are better tolerated by the patients, all recommendations today are for polymeric formula diets in Crohn's disease. There are some studies, there are only very few with very good results on probiotics. And this is one study, a multi-center randomized double-blind placebo controlled study, 12 weeks with 150 patients almost. And you see when they use probiotics, the ulcerative colitis disease activity index was in a higher proportion, more than 50% reduced in the probiotics. Remission was higher in probiotics, and mucosal healing was also some higher in probiotics, but this was not significant. There's another similar study showing the same effect. But it's almost all we can offer to you. So there is not a lot of data here to give a general recommendation. Also, fecal microbiota transplantation was quite promising from the background, and specifically for ulcerative colitis. Probiotics have not shown any good results in patients with Crohn's disease. But when you look on this meta-analysis on microbiota transplantation, when you look clinical remission in all studies, no positive signal. When you look on the delivery routes, orally by tubes or endoscopically by colonoscopy, or if you look on different infusion, all have shown no clinical beneficial signal here. So at the moment, fecal microbiota transplantation cannot be recommended unless you do this in a clinical study setting. One study I like to show you in this field, it's quite interesting. And they used microbiota transplantation in refractory ulcerative colitis patients. And they found with the transplantation, 70% of the patients had a clinical response. And almost 50% of the patient achieved clinical and endoscopic remission at 12 weeks. The interesting thing is here, they looked on the donors. So it seems that donor A is different than donor C. You see, donor A had a higher remission rate than donor B and donor C. So in the near future, we have to see on the super donor, what are the microbiota in the super donor? So maybe we can capsule this in medications, and they can swallow the capsules with this super donor stool for treatment in these patients. Only one word about TGF-beta. You see here one study in pediatric Crohn's patients, and the remission rates compared to steroids and endonutrition were the same. And they found a signal on endoscopical improvement and histological improvement. But it's only shown in pediatric and adolescent patients. In adults, we don't have clear, good studies here to give a general recommendation. Only one word about TPN. TPN, we have only small studies. And you see, when you look on TPN, there's quite a long time you need TPN to get remissions. The remissions were quite good, but the number of patients enrolled in these studies are quite low. So TPN is not an option as a primary treatment. TPN is only an option in the pre-operative setting when you have patients with Crohn's or ulcerative colitis. They have to be operated and they have a very bad nutritional status. Then we can use parenteral nutrition. But for primary treatment, it's not recommended anymore. It's clear, and the patients have an acute attack. They have a lot of inflammation. They have more catabolic drivers. So they need some more calories than a usual person. Also, the proteins is recommended in the new guidelines to 1.2 to 1.5. It's clear we should estimate the requirements. We should introduce gradually as necessary malnourished and metabolic stress patients. But what is most important, more is not always better. And the worst scenario is to overfeed the patients and to put them in the bed. It is shown that muscle losses are increasing, inflammation is increasing. So this patient should be active as the clinical condition will allow. So to summarize this first part, in Crohn's disease, it could be possible to control a flare-up in 60% of cases, but the time it takes is crucial, and so the compliance is very bad. Anti-nutrition is less efficient than corticosteroids, but as I mentioned before, the best option would be nutrition and corticosteroids. When we look at ulcerative colitis, there is no specific therapeutic effect known. Nutrition is only supportive. We can replete or maintain the nutritional status. When we now come to the second part, the nutritional support in the remission situation, macronutrient deficiencies are rare for both diseases because they have adequate nutritional intake when they have no inflammation. But in some Crohn's patients, a low body mass index cannot be improved. We don't know exactly what are the reasons. But also in the remission phase, we have to think about malabsorption problems, previous surgery, small bowel problems, metabolic changes. Also, sometimes you have to deal with bacterial overgrowth. When we treat bacterial overgrowth, we have a better impact on nutritional status. Also, drugs interacting with the nutritional intake, we have to consider. For the micronutrients, it's clear B12 for Crohn's disease, specifically if you have a resection of the terminal ileum. Very important, vitamin D and calcium should always be replaced if the patient, or supplemented if the patient is under corticosteroid treatment. So I mentioned this before, the best nutrition support in remission phase is the so-called healthy, balanced Mediterranean diet. But also a healthy, balanced Indian diet can also be recommended because we have cereals, we have dairy products, we have a lot of vegetables and fruits. The diet should be very colorful. Each color has an antioxidant, so it's very important. Then we need also moderate in saturated fat, and we need to increase the omega-3 fatty acids in form of fish oil, olive oil, and so on. Also, a lot of data were produced in the past, also an exclusion diet, no clear data. But what we have to consider, some individual food intolerance can be seen in IBD patients. Specifically in your area, in Asia, lactose intolerance can be a problem. Other diet products, spices, herbs, fried, gas, generating foods, fiber-rich products can be sometimes poorly tolerated. And it makes sense that these patients will decrease the intake of this. Or nutrition supplements or seldom anti-nutrition can be recommended in patients with Crohn's disease if anti-nutrition cannot be treated sufficiently by dietary counseling. Some years ago, a study was published by Beluzzi in the New England Journal, a small trial, and they looked on the supplementation of omega-3 fatty acids in the maintenance treatment in inactive Crohn's disease. The results were very promising, but nobody was really believed in this data. And it took some years until we got the answer. The EPIC-1 and EPIC-2 studies were done in both studies with 360 patients. And you see, over 1 year, the supplementation of omega-3 fatty acids had no clinical effect on the remission percentage. We can still not tell the patient they should not take fish oil products. In a healthy diet, it's quite clear, but in a specific effect, we cannot get out of this. Probiotics, as in acute diseases, no convincing results in Crohn's disease. There are some probiotics nicely studied in remission in ulcerative colitis for E. coli Nisli, Lactobacillus rhamnosus. some data on ulcerative colitis in mild to moderate forms, and in pouchitis. I think the best study we have on probiotics in ulcerative colitis is a study from Cruz, a large study with 327 patients. And you see they looked on probiotics and the standard treatment with mesalazine. And you see the relapse rate are similar in mesalazine and the probiotics. Another nice study was published with Lactobacillus rhamnosus, the same design, and you see the probiotics and the standard treatment after 6 and 12 months have the same remission results. So it's very crucial. You have to look on each probiotic in each disease to see if it's working. You cannot explorate that one probiotic is working, that another one is doing the same job. Pouchitis, 8 different strains have here used. Prevention of pouchitis, and you see you can reduce pouchitis with the probiotics. You can also prevent pouchitis after a ileoanal pouch operation in the same amount. Some patients do very well, some patients will not have any significant changes. So to come up to the end, when I was a young physician, a young gastroenterologist, our patients with IBD were slim. Today, obesity, a major problem all over. Also in IBD patient, obesity is increasing in children and also in adults. And also we have some data that obesity has a negative impact on outcome. In Crohn's patients, early fistulas have been seen. If they have an acute attack, they have more activities. They have to be hospitalized more often, and they need earlier surgical intervention. Also, what we have to say, obese IBD patients should not reduce weight when they have an acute attack. They should only reduce weight if they are stable in remission, and then you can use all the current obesity guidelines. And this was my experience all over in my life. A lot of time I have seen how to treat best the patient, how to get the best results. But all the time there were some things they stopped me to go this way. This is a nice picture from Paris some years ago. You see the old Renault here in this picture. And with this, I thank you so much for your attention, and I'm be very happy to answer some questions. Thank you.
Thank you, Professor Remy Mayer. That was a very comprehensive talk on the role of nutrition. Can you unshare your slides?
Yes.
Yeah. Thank you once again for that very comprehensive talk. I'm sure there'll be more questions as we move forward. Just to start the ball rolling at this moment, you did mention about changing epidemiology of IBD in this part of the world. And I must say that when I was undergoing my post-graduation at that time, there was no Crohn's disease in India. Now, this I'm talking about 35, 40 years back, but now I think we have moved quite a bit. And as you rightly said, we don't know whether it's because of the diagnostic modalities which has improved or whether it is actually a changing epidemiology. You did mention about the role of malnutrition as a component of IBD, both Crohn's and ulcerative colitis, and possibly more in one than other. Now, about the probiotics, what you rightly mentioned, and I would like you to again tell us, is that where do you place probiotics in the management of IBD? Will you give it as a solitary therapy in mild diseases, or will you give it as an additional therapy in mild to moderate diseases? And we are now in the biologics situation where a lot of our patients are getting biologics. We're adding probiotics in this situation, whether it is advisable, not advisable. What can be the interaction between the biologics and probiotics and prebiotics? You mentioned about fecal microbiota transplantation. As of today, it is not in the guideline. So which are the patients where you would possibly still consider fecal microbiota transplantation? So these were some of my early questions.
Okay.
Yes.
Dr. Goenka, can we take these questions after the session, or do we go
maybe
ahead now?
we can just hear a minute from him and then we move on.
All right, over to you, Professor Remy.
Okay, I start from the back. Microbiota and the role of microbiota. I think and I believe that the microbiota are very crucial in these patients, because microbiota are changing when you change the environmental factors. And when I look in India, I have been in India many years ago and in India recently, or in Asia, a lot of things have changed. Hygienics is much more, the more food available. They eat more, also in India, more junk food than in the past. Also, increase in body weight has changed in India. Also, we see the people with the abdominal fat in India. This was not the case 20 years ago. So a lot of things changed, and they changed the microbiota. And there are data, the very good data already available, that the microbiota are different in Crohn's and ulcerative colitis than in healthy situations. But how can we see if it's real a pathogenic microbiota, and if it's clear it's a pathogenic microbiota, how we can change this bad microbiota to a good microbiota? Stool transplantation failed until now. Specific probiotics, they're only in ulcerative colitis some good data in keeping them more in remission with Lactobacillus rhamnosus or with E. coli Nisle. So we don't know. We need a lot to do more in this field.
So I think we will have some more questions maybe after the end of the second talk.
Yes, there are quite a few of them in the chat box, yes. Dr. Mejia. Thank you so much, Professor Remy.
When you think about probiotics given in the acute attack, I think everybody can take probiotics. They are not harmful. There are no side effects. They are good products, but if they change the outcome of this patient, we don't know. So it's absolutely not clear what kind of single strain or multiple strain, we don't know. So this is some answers of these two questions we had. We have other questions about epidemiological situation. I think we come back at the end.
Yes, Professor. I mean, there are plenty of them, so we request you to wait for the session.
Okay.
And thank you for this very educative and enlightening talk. Managing IBD is always so challenging, especially with the remissions. So, taking this forward, we'd like to invite Dr. Daphne, the Chief Dietitian and Head Department of Dietetics, Apollo Hospital at Chennai. She has more than 25 years experience, has various awards to her credit and publications of her research papers in national and international journals. Is a member of various professional societies. Daphne, I request you to take this forward, please.
Thank you, Anita. Thank you for the invite and a wonderful introduction. So gut microbiome has been spoken a lot of late, and it is a cornerstone of life and good health. And there are a lot of accumulating evidences proving that there is a good correlation between the non-communicable diseases like diabetes, hypertension, cardiovascular diseases, obesity. And here we have a wonderful speaker, Francois, Marcus. It's my pleasure to welcome you because she's done a lot of research with regard to, gut microbiota. And she is the professor, associate professor, head of a hypertension research laboratory, senior medical research fellow, Sylvia and Charles Charitable Foundation, National Heart Foundation Future Leader Fellowship, and from the School of Biological Sciences, Monash University. And she's a co-program manager of High Blood Pressure Research Council of Australia. It's indeed a pleasure to have you. And she's done a lot of research in this field, and we are really going to gain a lot out of her. And it's all yours. Please start your session.
No, thank you so much. That's a very kind introduction. It's my pleasure to be here today joining you from Australia. And I'm originally from Brazil. That's where my beautiful accent is from. And I'm really excited to share with you some of our latest results on how we can lower blood pressure manipulating the gut microbiome. So I want to talk about high blood pressure today because it continues to be, even during the pandemic, the #1 cause of death globally. And a major issue is that when we have elevated high blood pressure for a long period of time, this is called also hypertension, and it affects 1 in every 3 adults around the world. So we know today that we have about 1.3 billion people living with hypertension right now. And hypertension has an enormous health burden. It is known as a silent disease. And this is because people can have undiagnosed high blood pressure for many years or decades. This leads to a lot of different diseases, including people having a stroke or heart attack, having heart failure, aortic aneurysm, even dementia these days. And a major issue that we have is that out of every 5 people that have hypertension, we know that 4 remain with unmanaged or uncontrolled high blood pressure. So the main causes for that is either people don't know they have hypertension, so awareness programs that can screen people that have high blood pressure are of a high value in this setting. We also have an issue that people don't want to take medication, or people also that can be resistant to the current available medication. So there is a huge scope here for us to try to control blood pressure and reduce all of these different diseases. But hypertension is a really tricky disease to control because I'm a geneticist, and genetically speaking, hypertension is what we call multifactorial disease. This means that we have the influence of the human genome and epigenome with many environmental risk factors. And more recently, we propose that when we talk about how blood pressure is regulated, we also need to consider the gut microbiome. So our previous speaker mentioned about the gut microbiome, and I'd like to always add a definition because there's so many definitions out there. So the microbiota are the microorganisms, including bacteria, fungi, algae, archaea, and protists that are included in the environment. While the microbiome is actually those microorganisms as well as nucleic acids, so that means also viruses, and other environmental factors that we have, including microbial metabolites as well. And what is really important about the microbiome in the human body in particular is that the vast majority of the microbes in our body, they inhabit our large intestine or our gut. So one key factor that we have been focused in our research that I want to talk to you about today is dietary fibers. And dietary fibers are important because they are key for preserving the microbiome intact. So dietary fiber basically includes all types of carbohydrates that are not digested or absorbed in the small intestine. So that means that they're going to pass undigested to the large intestine. And they also have some degree of polymerization. They can be broadly categorized into non-starch polysaccharides, such as those present in cell walls. So we have here soluble fibers as well as insoluble fibers. And we can also have resistant starches. So these are stored as basically the plant's energy store, and they are really important carbohydrate source in the human diet. Here we have different types of resistant starches, but overall, the vast majority of them are what we consider fermentable fibers. This is important because fibers that are fermentable, they feed microbes in the gut. So a lot of the research that I'm going to show you today has been specifically focused on resistant starches. And a major issue that we have globally is that on average, people are having about 11 grams of dietary fiber a day, instead of the recommended in most countries, like in Australia, it would be about 25 to 30 grams a day. So we are not eating enough fiber in our diet. And an issue that we have is that if we look into the Australians, for example, we have every 5 people, only 1 of them will have enough fiber in their diet. So that would be just a bunch of people in this call, for example. And a major issue that we have when we're not having enough fiber is that we know that as we have more fiber, we have a decrease in all-cause mortality. We also have a decrease in cardiovascular mortality and incidence. And a major factor driving this decrease in mortality is systolic blood pressure. So the more fiber we have in our diet, usually the lower blood pressure. So I mentioned that this is really important for the gut, and I want to explain to you why and why we're doing the research in this area, and also why it's linking to some of the questions that the audience was asking before. So fiber is essential for gut epithelial barrier and also keeping the homeostasis. So we love our microbes. They're so important to help us digest so many different types of food, including fiber, but also production of many vitamins. But we want those microbes to stay in the intestine. So when we have a diet that is high in fiber, we have proliferation of microbes that digest fiber. This leads to a nice thick layer of mucus, shown here in green. And this means that we can keep a beautiful gut epithelial barrier. So that means that microbes stay in the gut where they are actually useful for us. When we now have a diet that is free in fiber, what happens is that we have a proliferation of microbes that digest that mucus layer. So you can see here that the mucus layer becomes much smaller, and that leads to the breakdown of the gut epithelial barrier. When we then have translocation of microbes and their metabolites into our systemic circulation, what happens is the activation of many inflammatory pathways that are a hallmark for the development of cardiovascular disease. So in the past 6 years, my team has working on the hypothesis that when we have a diet high in fiber, it will pass undigested until it reaches the large intestine. There, it is fermented by commensal bacteria, leading to the release of metabolites known as short-chain fatty acids that was also mentioned in the previous talk. This includes particularly acetate, that's the most common short-chain fatty acid, followed by propionate and butyrate. So these short-chain fatty acids, they're really important systemically. We know that they have a really important function in dampening systemic inflammation, but they also have a really important function feeding the cells in our intestinal wall. And these short-chain fatty acids, once they're done their job in the gut itself, they can pass through the portal vein, where they can be distributed to the rest of the body, and we believe that they can lower blood pressure. So I'll show you some of our initial studies in animal models that were fundamental to establish this model, and the results of our latest clinical trial as well. So we assume in our hypothesis that dietary fiber was going to change the gut microbiota, increase the production of short-chain fatty acids, and that was going to lower blood pressure. So in a study that we published in 2017, we showed that this is a plot showing changes in the microbiota, where you can see that there is a shift between the microbiota of animals fed a control diet with acetate in the drinking water, so we fed them directly to the animals, or a high fiber diet. And we saw in terms of their blood pressure that animals that had fiber or acetate in the diet, they went on to have substantial reduction in their systolic as well as their diastolic blood pressure. This is quite remarkable. We work with a lot of pharmacological agents, and sometimes we cannot achieve the same levels in animal models using these pharmacological agents compared to what we're seeing here with diets. But what we wanted to understand as well is whether high fiber diets are just improving blood pressure, or whether if we remove dietary fiber from that's whether we're going to then increase blood pressure. So what we did was to feed animals a diet low in fiber or high fiber, and then we challenged them to see how they would respond to a hypertensive challenge. And we saw that those animals went on to develop, when they had a low fiber diet, higher heart sizes, as well as higher blood pressure, as well as more fibrosis in the heart. So you can see the fibrosis here in these photos in blue. So fibrosis makes the heart really stiff, and by making the heart stiff, it makes the heart really hard to contract. So this is really important for the development of heart failure later on. What we wanted to understand next was whether these changes that we're seeing were just merely an association that low fiber was leading to high blood pressure, or whether that was indeed being produced by the microbiota that was driving these changes. So what we did was to take the microbiota from conventional mice, and we did a fecal microbiota transplantation into germ-free animals. So these are animals that they don't have any types of microbes, so they're a really powerful tool to use in these studies to understand the role of microbes. And what we saw is that indeed animals that received a fecal microbiota transplantation from animals that received a low fiber diet went on to develop higher systolic and diastolic blood pressure, as well as higher heart size and more fibrosis. So this shows that when we have a diet that lacks dietary fiber, it leads to changes in the microbiota that on their own are able to drive an increase in cardiovascular disease. Next, we wanted to understand whether we were able to rescue this phenotype using short-chain fatty acids directly. So we added short-chain fatty acids in the drinking water of our animals. And what we saw is that these animals that received acetate, propionate, butyrate, or combination of all three went on to have smaller heart sizes, smaller, lower blood pressures, as well as less fibrosis in their heart. So this shows that these molecules called short-chain fatty acids can be quite powerful in perhaps preventing the development of cardiovascular disease, at least in animal models. We're also interested in understanding whether this cardiovascular protection can be inherited. So whether if we fed pregnant mice diet high in fiber, we could prevent the development of cardiovascular disease in the offspring. So this is a study that is currently under peer review, but the preprint is available on bioRxiv if anyone is interested. And the logic for this is that we know that there are many different types of early life exposure, including, for example, high levels of protein that can later determine the susceptibility to development of disease, including metabolic syndrome. So we assume that maternal high fiber intake would be digested by the microbiota. It would release metabolites such as short-chain fatty acids, and that was going to lead to epigenetic modifications that would persist in the offspring. So we wanted to understand whether the offspring was going to be protected against the development of cardiovascular disease. And what we observed is that indeed that animals that the mothers had high fiber, so these animals are always on the same diet between the low fiber and high fiber offspring, but the mothers had high fiber, they had a smaller heart to body weight ratio, they had less hypertrophy of their heart. They also had improved ejection fraction, so their hearts work better. And they also had lower levels of natriuretic peptides that are involved in the development of heart failure. We also wanted to understand the role of this maternal fiber intake in fibrosis in the offspring. So what we observed is that indeed high fiber diet from the mothers was able to prevent the development of the heart becoming really stiff in the offspring, which is a hallmark for the development of heart failure later in life. And this was at both of the histological level as well as the molecular level that we saw many changes associated with genes that are involved in production of fibrosis. But I think for this audience, it's particularly important to highlight the human component of these studies and the potential for translation. So we have now a series of studies where we show that in essential hypertension, there are many changes in the gut microbiota that are associated with production of short-chain fatty acids. So either changes in microbes that are associated with production of short-chain fatty acids, or levels of short-chain fatty acids, or sometimes some of the key receptors that sense levels of short-chain fatty acids in our body and can respond to that. We also saw that patients that have heart failure with preserved ejection fraction have major changes in the gut microbiome, particularly microbes that are some of the key fiber digesters. And we also see similar changes in arterial stiffness, as well as more recently in blood pressure variability. But what I wanted to talk to you about in the next minutes towards the end of this talk is translating this to something that patients could actually take to lower their blood pressure. So what I showed you before is that dietary fiber acting via the gut microbiota and the production of short-chain fatty acids can lower blood pressure. But all the evidence from our team, and now many others have validated those findings, have been in mice. So our hypothesis is that short-chain fatty acids would also lower blood pressure in people. So to do this, we designed a randomized clinical trial. So this was a phase 2 trial. The design of the trial is available on Trials. And what we did was to do a crossover placebo-controlled double-blind randomized trial. But a major challenge that we had is that we needed people to be able to go on either the placebo or the short-chain fatty acid enriched fiber without knowing which one they were having, that the foods that they were receiving had to taste the same, smell the same, and people needed to want to eat that food for the 3-week period. So this was a major challenge because there are many complications in terms of compliance. So to be able to increase compliance, we engaged with a research chef and research dietitians as well. And they developed foods that basically look the same, taste the same, smell the same, including sweet and savory muffins. We had frittatas, arancini balls, burgers, and so on, that were delicious, and people were happy to have that. So we completed this study recently. As you can imagine, and I'm showing Inya as well, we had major issues with recruitment during COVID, but we're able to recruit all the participants for the trial by the end of last year. And these results that I'm going to share with you, we just submitted them for peer review. They are now available in preprint as well. And with that, we're able to achieve, with these modifications, 93% compliance in both arms of the study. So this study is now available at medRxiv until it is peer-reviewed and printed. So the first thing that it's important to highlight is that indeed we're able to increase the levels of short-chain fatty acids by nearly 8 times. And this was measured about 12 hours after the participant's last meal. So potentially the levels a few hours later, the meal would be even higher. But what was really important here is that we observed a placebo-subtracted treatment mean difference of 6.1 millimeters mercury in 24-hour systolic blood pressure. So this was done after we did general linear models that were adjusted by carryover effect, BMI, sex, age. And these levels are basically calculated to reduce coronary death by 9% and stroke death by 14%. So what we can conclude is that indeed interventions that increase levels of short-chain fatty acids can lower blood pressure in patients that are untreated for high blood pressure. We don't know now whether this can also be achieved in other patient groups, and that's something that we're keen to explore next. So in summary, we have shown you that the microbiota is key in improving blood pressure control via production of short-chain fatty acids when we have diets high in fiber. And when we have diets low in fiber, this results in a gut microbiota that drives cardiovascular disease. It's not just merely associated with it. We also show that short-chain fatty acids can reduce blood pressure in both animal models as well as in people. And these can come from interventions, even just having high fiber muffins, for example. So indeed, the way to a person's heart is through their stomach. So for the clinicians watching this talk, what I wanted to mention next is what you can do for now. So the supplement that we use is currently not available for commercial purposes, but as we know, some of the best diets to lower blood pressure is still the DASH and the Mediterranean diets. In this study published in the Lancet, where they looked into different fiber thresholds, what they found is that fibers that had at least 25 to 29 grams a day, they were able to significantly reduce all-cause mortality, cardiovascular mortality and incidence, and stroke incidence. But there is an added benefit from increasing it further to at least 35 grams a day. But remember that fibers are not all the same. There are many different types of fiber, and the best way would be to consume a varied type of fiber, such as we have when we consume a Mediterranean diet. And particularly, we have been interested in fermentable fibers, and we use resistant starches as a fantastic source of fermentable fiber in our studies. Sources for that will include bananas when they're still green, potatoes, pasta, and rice when it's cooled, when it's cooked and cooled down. Even if you reheat it later, it still changes the structure of the starches. We also have high sources would be nuts such as pistachios, as well as cashew nuts, and many other different types of beans and lentils, for example. So I just want to thank everybody that has been involved in many of these studies, my team at Monash University, as well as our funding bodies, and I'm happy to answer any questions.
Thank you so much, Dr. Marcus, for such an enlightening talk. You indeed took us right through the fiber, and it's like recapping everything, whatever we had learned, and showing so much of evidence in order to strengthen our practice. And you did give a detailed account on fiber leading to, decreasing all-cause mortality. And it was really an, welcoming talk today. Really, it's a pleasure to be here. I know all the participants would support me in saying that. And I would like to ask you a few things with regard to phytochemicals and probiotics. Do you have any work done with regard to gut microbiome? What is the evidence?
Yeah, with probiotics, we haven't done any studies. The main issue with probiotics is that most studies either have a small sample size or they use different types of probiotics and strains in each. That makes combining results and doing meta-analysis really tricky. Another main issue that I personally have is that if we are adding new microbes to our gut, either we might not miss, we might already have those microbes in the first place, so they're not going to do anything. Or if we didn't have those microbes, but now we're adding those microbes, but we're not adding what they actually need, the foods that they need to be able to survive in our gut and thrive, because they thrive and help our health by producing metabolites. If we're not feeding them the right types of food, we're not going to get the benefit. So if people are keen in having probiotics, I would suggest that you need to consider also adding prebiotics to your diet, so types of foods that feed those microbes to get the most benefit.
Okay, thank you. So what is your take on phytophenols?
I haven't done any studies on that, so I can't comment.
Okay. So with regard to whatever work that you have done, you did talk about hypertension and about cardiovascular disease. Did you have patients who were obese in that category? Did that have an impact? Can you throw some light on that?
Yeah, the cutoff for the study, the BMI was 35. So we did have patients that were obese, as most patients with hypertension are these days, at least in Australia, and we still saw a benefit. We do, similar to what Dr. Meyer was mentioning before, that we see that not everybody is a responder. We next need to try to understand who is a respondent and who is not. And I believe that that's going to lie on their baseline microbiota and their ability to digest fiber and produce short-chain fatty acids. But we don't know that yet.
Okay. Thank
Dr.
you.
Goenka, you also had a few questions.
Yeah,
We wanted to, yeah.
I must say I'm mesmerized by your presentation. Never had this concept that fibers can cause blood pressure changes. I must compliment you for the original work which has been done and published. One or two questions to you. Is there any difference between various short-chain fatty acids? You did talk about one of the study that acetate was added. So why did you choose acetate over the other short-chain fatty acids? And about your clinical human trials, which you talked about, what was the baseline characteristics of these patients? Were there mild hypertension? Were there a variety of spectrum of hypertension? What was the initial BP like? Professor Marcus?
Yeah, she's just given a message that her laptop batteries run out.
All right. So before she joins, can we have one
Yeah.
question to?
Yeah, Professor Remy can take
yes.
them in the meanwhile.
So there was a question about immunomodulators and immunonutrition rather in IBD. So do you think there's a role? We get a lot of people talking about glutathione and the other immunonutrients.
The short answer is no. There are no data. Also, immunonutrition per se, if it's glutamine, it's arginine, it's whatever, there's no good studies, and secondly, the results were also very bad. So there is no recommendation for any immunonutrition in IBD patients.
So I would just like to share one data which we had a very extensive study from India, that response to biologics was related to initial albumin level. So maybe the nutrition decides whether the drugs are going to act also or not. Any comment on that?
You know, albumin levels, they only reflect disease activity. If you have high disease, you have high CRP levels, albumin is down. And the albumin is only coming up if you fight first inflammation, and inflammation goes down, and you give good nutritional support. So it's clear also when the patients are on immunologics, they need time to recover, and the immunologics have some side effects on maybe the nutritional status per se. And when you both things, you treat inflammation and good nutritional support, then you have an impact on the disease activity, and also then the albumin levels will raise. There are some data on the immunologicals that if you add good nutritional support, they respond better if you do not add good nutritional support.
So one more question to you.
Yeah, Dr. Goenka, even Professor Marcus has joined back.
Yeah, Professor Marcus,
Welcome back.
Missed you for some time.
Yeah.
I don't know whether you heard my compliment to you. It was marvelous presentation, mesmerizing talk. My question to you was that, is there any difference between various short chain fatty acids which you talked about? You did talk about one study where acetate was added. So why did you choose acetate rather than other short chain fatty acids? And my second question is that what was the baseline blood pressure of your clinical human study? Were they all mild hypertensive, or there was a spectrum?
We use 24-hour blood pressure monitoring based on Australian guidelines as a cutoff. We also put a cutoff at 160 millimeters mercury systolic because we didn't want anyone to have a cardiovascular event while in the trial. So it was quite a stringent selection criteria. In terms of the short chain fatty acids, we chose acetate and butyrate based on our preclinical studies because we saw that those two had the biggest effect in lowering blood pressure as well as improving gut epithelial barrier.
What was the amount of short chain fatty acids you put it in your diet?
Yeah, the amount it's hard to determine the specific amount. We had 20 grams a day, twice a day for the participants. So, so with that in mind, we had out of those 20 grams a day, 10 of those were resistant starches, but they're all linked to short chain fatty acids. So they enriched for short chain fatty acids. So it's not something that you can achieve just by drinking it in a shake, for example, because the problem that you have with that is that it would peak, and a colleague did a study like that, it would peak within 30 to 60 minutes, and then the levels were going to go down. And we needed something that was going to deliver that at a constant level for much longer. And that's what we were able to achieve with the diet, that the results I showed you were, the samples were collected 12 hours later and we're still seeing high levels.
How was the compliance to the fiber monitored, Marcus?
93% in both placebo and fiber arms.
So when we give fibers to our irritable bowel syndrome patients, they often complain of bloating, too much of bloating. So did you find any of the problems in your mice? Of course, will not complain of bloating, but what about human beings?
Yeah, we use the VAST scale to monitor for gastrointestinal symptoms, and we did not see any differences between the fiber and the placebo interventions.
Great.
How many had IBS as a comorbid condition in your study?
We didn't include people that had IBS because we knew that that was going to already change the microbiome. So we were quite concerned about keeping the sample. The selection criteria was quite strict, but making sure that people had a similar phenotype so they were comparable.
So I think we have overshot our time for the day. So should we wind up, Anita ji?
Yeah, please. Thank you so much. Thank you, Dr. Mahesh, for being here. You want to say
No,
the
I just wanted
concluding
to thank
remarks?
both the speakers. I would just want to thank both the speakers and everybody who was present. I think we had wonderful discussion on both the topics, and I'm sure the future is bright. Let's see.
Yeah, just
Thank
would
you.
like to really thank Dr. Anupam Sibal, President GAPIO, and the organizing team of GAPIO for this opportunity, to the dietetics team. And a big thank you, Dr. Tandon, for all your help and guidance. You're always there. Big thank you to our esteemed speakers who really just, responded on this short notice. Very, very enlightening talks and a lot of take-home messages for all the participants. Thank you, Professor Remy and Professor Marcus,
you.
for this excellent session.
Thank you,
Thank
Doctor.
you.
Thank
Thank
you.
you.
To the participants.
Bye-bye.
Thank
very
you.
much.
Goodbye.
Bye-bye. Bye-bye.
Bye-bye.
Thank
Let
you,
me
Dr.
thank
Remy.
also Professor Meyer. Let
See
me
you in
also
Vienna.
thank Professor
See you in Vienna.
Parsin
Yes, doctor. I'll meet you
and
in Vienna.
Dr. Daphne, Dr. Mesh Goenka, and Dr. Anita. Thank you very
sir.
much for your time. And this was a very, very, informative session. And
Yes.
thank you very much for joining. We'll
Thank
be
you,
in touch
Dr.
with
Anil.
you.
Bye-bye.
Thank you.
Thank you,
sir.
thank you.
Thank you so
Bye-bye.
much. Bye-bye.
Bye,
Thank you,
Dr.
everybody.
Remy. Bye-bye.
Bye.
All right.